Every single day, millions of older adults swallow their morning medications without a second thought. A blood pressure pill, a cholesterol drug, a common over-the-counter painkiller, maybe a supplement or two recommended by a well-meaning friend. What most of them don't know, and what most doctors don't have time to explain in a 12-minute appointment, is that certain combinations of these everyday medications can trigger reactions inside the body that are, in clinical terms, life-threatening. This is not rare. Drug-drug interactions are among the most underreported and under-recognized causes of hospitalizations in adults over 65. According to research published in the Journal of the American Geriatric Society, approximately 35% of older adults take 5 or more medications daily, a practice called polypharmacy, and that number rises steeply with age. Each additional drug added to a regimen doesn't just add its own risks, it multiplies the interaction possibilities exponentially. Today we're going to walk through the most dangerous and most common drug combinations that research has identified as high risk, explaining exactly what happens at the biochemical level, which drugs are involved, what the warning signs look like, and what questions to bring to your doctor or pharmacist. This is not about fear, it is about being an informed participant in your own healthcare. Let's begin. Combination number 1, warfarin plus NSAIDs, aspirin, ibuprofen, naproxen. What these drugs are: warfarin, brand name Coumadin, is an anticoagulant, a blood thinner, prescribed to millions of older adults to prevent strokes and blood clots, particularly in those with atrial fibrillation, deep vein thrombosis, or mechanical heart valves. NSAIDs, non-steroidal anti-inflammatory drugs, include over-the-counter medications like aspirin, Bayer, Bufferin, ibuprofen, Advil, Motrin, and naproxen, Aleve. They are among the most widely used drugs on the planet, taken casually for headaches, arthritis pain, and back pain. Why this combination is dangerous? The danger here operates through 2 simultaneous mechanisms, and understanding both is essential. First, warfarin's anticoagulant effect works by inhibiting vitamin K-dependent clotting factors in the liver, specifically factors Tau, 2, 7, 9, and X in the coagulation cascade. The therapeutic goal is to thin the blood just enough to prevent dangerous clots from forming, while not thinning it so much that uncontrolled bleeding occurs. This is a narrow therapeutic window measured regularly through a blood test called the INR, International Normalized Ratio. A healthy INR for most warfarin patients is between 2.0 and 3.0. NSAIDs disrupt this balance in a critical way. They inhibit the enzyme cyclooxygenase, COX, which is responsible for synthesizing thromboxane A2 in platelets. Thromboxane A2 is what causes platelets to clump together and form the initial plug at a site of bleeding. When NSAIDs inhibit COX, platelet aggregation is impaired, meaning the body's first line of hemostasis, bleeding control, is compromised at the exact same time that warfarin is suppressing the second line, clotting factors. Second, NSAIDs, particularly aspirin and ibuprofen, irritate and damage the gastric mucosa. They inhibit prostaglandin synthesis in the stomach lining, reducing the protective mucus layer and making the stomach lining vulnerable to erosion and ulceration. In a patient already on warfarin, even a small gastric ulcer can bleed catastrophically and without warning. The bleeding may be entirely internal, undetected until the patient presents in an emergency room with dangerously low hemoglobin. Additionally, some NSAIDs, particularly aspirin, can displace warfarin from plasma protein binding sites, increasing free warfarin concentration in the blood and unpredictably elevating INR. What the research says: a landmark study published in the Archives of Internal Medicine found that concurrent use of warfarin and NSAIDs increased the risk of serious gastrointestinal bleeding by approximately 3-fold compared to warfarin alone. A 2015 meta-analysis in the British Journal of Clinical Pharmacology confirmed that this combination significantly elevated hospitalization rates for hemorrhagic events in patients over 65. The warning signs: unusual bruising or bruising that spreads rapidly, blood in urine, pink, red, or cola-colored, black, tarry, or bloody stools, prolonged bleeding from cuts, coughing or vomiting blood, sudden severe headache may indicate intracranial bleeding. What to discuss with your doctor. If you are on warfarin and need pain relief, ask about acetaminophen, Tylenol, as an alternative. It does not affect platelet function or displace warfarin the way NSAIDs do, though high doses can still affect INR and must be monitored. Topical NSAIDs, diclofenac gel, may also be an option for localized joint pain with lower systemic absorption. Combination number 2, ACE inhibitors, ARBs, plus potassium-sparing diuretics. What these drugs are: ACE inhibitors, lisinopril, enalapril, ramipril, and ARBs, losartan, valsartan, olmesartan, are first-line treatments for hypertension and heart failure. They work by blocking the renin-angiotensin-aldosterone system, RAAS, a hormonal cascade that regulates blood pressure and fluid balance. By inhibiting angiotensin-converting enzyme or blocking angiotensin II receptors, these drugs reduce vasoconstriction and lower aldosterone levels. Aldosterone normally signals the kidneys to retain sodium and excrete potassium. When ACE inhibitors or ARBs suppress aldosterone, potassium is retained. In most patients, this is a mild and manageable effect. Potassium-sparing diuretics, spironolactone, eplerenone, amiloride, triamterene, are often prescribed alongside diuretics to prevent potassium loss, hypokalemia, which is a known side effect of loop diuretics like furosemide and thiazide diuretics like hydrochlorothiazide. The problem occurs when potassium-sparing diuretics are combined with ACE inhibitors or ARBs without careful monitoring. The mechanism of danger: hyperkalemia. Both drug classes independently cause potassium retention. When used together, the additive effect on potassium levels can push serum potassium dangerously high, a condition called hyperkalemia. Normal serum potassium is 3.5 points EUR/MEQL. At levels above 5.5 MEQL, cardiac conduction abnormalities begin. At levels above 6.0-6.5 MEQL, life-threatening arrhythmias can occur, including ventricular fibrillation and sudden cardiac arrest. The cardiac mechanism: potassium is the primary ion governing the resting membrane potential of cardiomyocytes. When extracellular potassium rises, the resting membrane potential of cardiac cells becomes less negative, a process called depolarization. This reduces the cell's ability to fully repolarize between beats, leading to conduction delays, wide QRS complexes on ECG, and ultimately fatal arrhythmias if untreated. This combination is responsible for a significant proportion of drug-induced cardiac deaths in older adults. A landmark Canadian study published in the New England Journal of Medicine found that after the heart failure treatment guidelines began recommending spironolactone combined with ACE inhibitors in 1999, rates of hyperkalemia-related hospitalizations and sudden deaths rose sharply in older patients, many of whom were not receiving the close monitoring the original trial required. Potassium from diet and supplements. The risk is compounded when patients on this combination also consume high potassium diets, bananas, oranges, potatoes, tomatoes, leafy greens, or take potassium supplements, sometimes purchased over the counter, without awareness of their interaction potential. Warning signs of hyperkalemia: muscle weakness or paralysis, fatigue and heaviness in the limbs, palpitations or irregular heartbeat, nausea. Numbness or tingling, particularly in the face, hands, feet. In severe cases, no warning. Sudden cardiac arrest. What to discuss with your doctor. Patients on this combination should have serum potassium levels checked within 1 week of starting or adjusting doses, and then regularly thereafter. Dietary potassium should also be reviewed. If you take potassium supplements, ensure your prescribing physician and pharmacist are both aware. Combination: NRCA3, SSRIs, plus NSAIDs, or aspirin. What these drugs are. SSRIs, selective serotonin reuptake inhibitors, include some of the most commonly prescribed medications in the world: fluoxetine, Prozac, sertraline, Zoloft, escitalopram, Lexapro, paroxetine, Paxil, and citalopram, Celexa. They are prescribed for depression, anxiety disorders, OCD, PTSD, and panic disorder. In older adults, they are often the first-line treatment for depression, which is significantly underdiagnosed in the 60-plus population. NSAIDs and aspirin, as covered above, are taken daily by enormous numbers of older adults. Aspirin in particular is still self-prescribed by millions for cardiovascular prevention, even as guidelines have evolved. The mechanism. Bleeding risk at the GI level. Serotonin is not just a neurotransmitter in the brain. Approximately 95% of the body's serotonin is found in the gastrointestinal tract and in platelets. Platelets absorb serotonin from the bloodstream via the same transporter that SSRIs block in neurons, the serotonin transporter, SART. Platelets use stored serotonin as a signaling molecule during the clotting process. It is released upon platelet activation and contributes to vasoconstriction and further platelet aggregation at a wound site. When SSRIs block SART, platelets are depleted of serotonin. This impairs the platelet activation cascade, reducing their ability to form a stable clot. This effect is additive when combined with NSAIDs, which simultaneously inhibit COX-mediated thromboxane A2 production. The result: two independent mechanisms of platelet dysfunction occurring simultaneously, creating a significant bleeding risk, particularly in the gastrointestinal tract. What the research says: a large population-based cohort study published in the British Medical Journal found that patients taking both SSRIs and NSAIDs had a 15-fold increased risk of upper gastrointestinal bleeding compared to patients taking neither drug. Research published in Alimentary Pharmacology and Therapeutics found that adding a proton pump inhibitor, PPI, to this combination significantly reduced, though did not eliminate, the bleeding risk. Additionally, SSRIs combined with aspirin have been associated in multiple studies with increased risk of intracranial hemorrhage, though the absolute risk remains low for most patients. What to discuss with your doctor. If you're on an SSRI and regularly use NSAIDs for pain, discuss whether a PPI, such as omeprazole or pantoprazole, should be added as gastroprotection. Also review whether daily low-dose aspirin is still indicated for your cardiovascular risk profile. Guidelines now recommend against it for primary prevention in many older adults due to bleeding risks. Combination. Number 4, statins, plus certain antibiotics or antifungals, CYP3A4 inhibitors. What these drugs are: statins, atorvastatin, Lipitor, simvastatin, Zocor, lovastatin, Mevacor, rosuvastatin, Crestor are among the most prescribed drugs globally used to lower LDL cholesterol and reduce cardiovascular risk. CYP3A4 inhibitors include a range of commonly prescribed antibiotics and antifungals: clarithromycin, Biaxin, erythromycin, fluconazole, diflucan, itraconazole, and ketoconazole. Some HIV medications, ritonavir, calcium channel blockers, diltiazem, verapamil, and even certain foods, grapefruit juice, also potently inhibit CYP3A4. The mechanism: statin toxicity. Most statins, particularly simvastatin and lovastatin, are metabolized primarily by the cytochrome P450 3A4 enzyme system in the liver and intestinal wall. CYP3A4 is responsible for metabolizing a large percentage of all drugs, and it is a critical regulator of drug concentration in the bloodstream. When a CYP3A4 inhibitor is introduced, the enzyme's activity is suppressed, sometimes dramatically. Drugs that normally would be broken down and cleared are instead allowed to accumulate. For statins, this means plasma concentrations can rise to many times their normal levels. Elevated statin concentrations dramatically increase the risk of rhabdomyolysis, a severe breakdown of skeletal muscle tissue. In rhabdomyolysis, muscle cells rupture and release their contents, including the protein myoglobin, directly into the bloodstream. Myoglobin is toxic to the kidneys. It precipitates in the renal tubules and causes acute kidney injury, which can progress to acute renal failure. The mechanism at the cellular level involves mitochondrial dysfunction. Statins inhibit the mevalonate pathway, which produces not only cholesterol but also coenzyme Q10, CoQ10, a critical component of the mitochondrial electron transport chain. When CoQ10 is significantly depleted, ATP production in muscle cells collapses and the cells begin to die. What the research says: the FDA has issued black box warnings for simvastatin in particular when combined with strong CYP3A4 inhibitors. Case reports and pharmacovigilance databases consistently document rhabdomyolysis events occurring within days to weeks of adding a CYP3A4 inhibitor to a statin regimen. A review in drug safety noted that simvastatin and lovastatin carry far higher interaction risk than rosuvastatin or pravastatin, which are metabolized through different pathways and represent safer alternatives in patients requiring CYP3A4 inhibiting drugs. Warning signs of rhabdomyolysis: severe, unexplained muscle pain or weakness, particularly in the thighs, shoulders, or lower back; dark, brown, or tea-colored urine; myoglobinuria; decreased or no urine output; nausea, vomiting, confusion; fever. This is a medical emergency. If muscle pain develops alongside any change in urine color in a patient on statins, emergency evaluation is required. What to discuss with your doctor. If you are prescribed a new antibiotic, antifungal, or any new medication while on a statin, ask specifically, does this affect CYP3A4? If it does, your physician may temporarily suspend your statin, switch you to a statin with lower interaction risk, rosuvastatin, pravastatin, fluvastatin, or choose an alternative antibiotic. Never drink grapefruit juice while on simvastatin or lovastatin. It contains furanocoumarins that irreversibly inhibit intestinal CYP3A4 for up to 72 hours. Combination number 5, digoxin plus amiodarone, verapamil, or certain antibiotics. What these drugs are. Digoxin is a cardiac glycoside derived from the foxglove plant, Digitalis purpurea, and has been used for over 200 years to treat heart failure and atrial fibrillation. It has an extremely narrow therapeutic index, meaning the difference between a therapeutic dose and a toxic dose is very small. Amiodarone is a powerful antiarrhythmic drug used to restore normal heart rhythm in atrial fibrillation and ventricular arrhythmias. Verapamil is a calcium channel blocker used for hypertension and certain arrhythmias. Both are frequently prescribed in older adults with cardiac conditions, the same population most likely to also be on digoxin. The mechanism. Digoxin toxicity. Digoxin works by inhibiting the Na+, K+ ATPase pump on the surface of cardiomyocytes. This pump normally maintains the electrochemical gradient across the cell membrane. By inhibiting it, digoxin causes intracellular sodium to rise, which secondarily causes intracellular calcium to rise through the sodium-calcium exchanger. This increased intracellular calcium enhances cardiac contractility, positive in atrophy, useful in heart failure, and slows conduction through the AV node, useful in rate control for atrial fibrillation. The problem: digoxin's therapeutic plasma level is narrow, 0.5 to 2.0 ng/ml. At levels above 2.0 ng/ml, toxicity begins. Amiodarone increases digoxin levels substantially by 70-100% in many patients through multiple mechanisms. It inhibits P-glycoprotein, which normally exports digoxin from cells, reduces renal clearance of digoxin, and inhibits CYP enzymes involved in its metabolism. Verapamil similarly reduces digoxin clearance and can elevate plasma levels by 50 to 75%. Certain antibiotics, particularly clarithromycin and erythromycin, eliminate gut bacteria, especially Eggerichia lenta, that normally metabolize digoxin in the intestine before it reaches systemic circulation. When these bacteria are wiped out, more digoxin is absorbed, pushing plasma levels dangerously high. Symptoms of digoxin toxicity: nausea, vomiting, loss of appetite, visual disturbances, particularly yellow-green vision, xanthopsia, or halos around lights, confusion, dizziness, weakness, bradycardia, heart rate below 60 BPM, life-threatening arrhythmias, including heart block and ventricular tachycardia. What the research says? Multiple studies confirm that digoxin toxicity is one of the most common adverse drug events in older hospitalized patients. A review in the American Journal of Geriatric Pharmacotherapy found that drug interactions, particularly with amiodarone, accounted for a substantial proportion of digoxin toxicity cases, many of which were preventable. Digoxin levels should be rechecked within 1 week of adding amiodarone, verapamil, or any macrolide antibiotic. Combination Nurker-6, opioids, plus benzodiazepines. What these drugs are: opioids, oxycodone, OxyContin, Percocet, hydrocodone, Vicodin, codeine, tramadol, morphine, are prescribed for moderate to severe pain, which is extremely common in older adults managing osteoarthritis, post-surgical pain, cancer pain, and neuropathy. Benzodiazepines: diazepam, Valium, lorazepam, Ativan, alprazolam, Xanax, clonazepam, Klonopin, temazepam, Restoril, are prescribed for anxiety, panic disorder, and insomnia. They are widely used in older adults, often for years or decades, despite guidelines recommending against their long-term use in this population. The mechanism: synergistic CNS and respiratory depression. Both drug classes depress the central nervous system, but through different mechanisms. Opioids bind to mu-opioid receptors in the brainstem, including the pre-Butzinger complex, the brain's primary respiratory rhythm generator. Activation of these receptors reduces the sensitivity of the respiratory center to carbon dioxide, slowing breathing rate and depth. And benzodiazepines bind to GABA-A receptors throughout the CNS, enhancing the effect of gamma-aminobutyric acid, GABA, the brain's primary inhibitory neurotransmitter. This produces sedation, anxiolysis, and, crucially, additional respiratory depression through a completely independent pathway. When both drugs are taken together, their respiratory depressant effects are not merely additive, they are synergistic. The combination can suppress breathing to the point of hypoxia, dangerously low blood oxygen, hypercapnia, dangerously high CO2, respiratory arrest, and death during sleep, often without the person ever waking up. This combination now carries an FDA black box warning, the most serious warning level, explicitly stating that combined use can result in profound sedation, respiratory depression, coma, and death. What the research says: a 2017 analysis published in the British Medical Journal examined over 400,000 patients and found that patients co-prescribed opioids and benzodiazepines had a significantly higher risk of opioid overdose death compared to patients on opioids alone, and the risk scaled with benzodiazepine dose. The CDC's opioid prescribing guidelines explicitly identify this combination as one of the highest priority targets for deprescribing efforts. In older adults, the risk is compounded by age-related changes in pharmacokinetics. Slower liver metabolism, reduced renal clearance, and increased blood-brain barrier permeability mean that both drugs achieve higher and more prolonged concentrations in older patients at the same doses that younger patients tolerate. Other drugs that compound this risk. The risk is not limited to prescribed benzodiazepines. Other CNS depressants that interact dangerously with opioids include muscle relaxants, cyclobenzaprine, carisoprodol, sleep aids, zolpidem, Ambien, ezopaquone, Lunesta, gabapentin, Neurontin, pregabalin, Lyrica, and alcohol. What to discuss with your doctor? If you are on both an opioid and a benzodiazepine, discuss whether both are still medically necessary. Benzodiazepines are generally not recommended for long-term use in older adults due to multiple risks, including falls, cognitive impairment and dependence, and the interaction risk with opioids adds urgency to that conversation. Never adjust or stop benzodiazepines suddenly. Tapering under medical supervision is required to avoid withdrawal seizures. Combination number 7, Metformin plus contrast dye, iodinated contrast media. What these drugs are. Metformin glucophage is the most widely prescribed oral medication for type 2 diabetes worldwide. It works primarily by reducing hepatic glucose production via AMPK activation, suppressing gluconeogenesis, and improving peripheral insulin sensitivity. Iodinated contrast media are substances injected intravenously during imaging procedures, CT scans with contrast, cardiac catheterizations, angiograms to make blood vessels and organs visible on imaging. The mechanism: lactic acidosis. Metformin itself rarely causes lactic acidosis in patients with normal kidney function. However, iodinated contrast agents are nephrotoxic. They can cause acute kidney injury, contrast-induced nephropathy, by inducing renal vasoconstriction and direct tubular toxicity. When kidney function drops acutely after contrast administration, metformin, which is eliminated almost entirely unchanged by the kidneys, cannot be cleared. It accumulates rapidly. Metformin at elevated concentrations inhibits mitochondrial complex Y of the electron transport chain, impairing oxidative phosphorylation. As cells switch to anaerobic glycolysis, lactate accumulates. The result is metformin-associated lactic acidosis, MALA, a rare but potentially fatal condition with mortality rates reported between 30–50% in severe cases. What the research says, the FDA and European Medicines Agency both recommend withholding metformin at the time of or prior to iodinated contrast procedures in patients with renal impairment and in all patients for 48 hours after contrast administration. Kidney function, eGFR, should be reassessed before restarting. Research in radiology and other journals has confirmed that while contrast-induced nephropathy rates have decreased with newer contrast agents, the metformin interaction risk remains clinically relevant, particularly in older adults with borderline renal function who may not be routinely tested. What to discuss with your doctor. If you take metformin and are scheduled for any imaging procedure involving contrast dye, inform both your prescribing physician and the radiology team. This should be standard practice but is frequently missed, particularly in emergency settings or when imaging is arranged by a specialist who is not aware of the full medication list. Combination number 8, fluoroquinolone antibiotics plus QT prolonging drugs. What these drugs are: fluoroquinolone antibiotics, ciprofloxacin, Cipro, levofloxacin, Levaquin, moxifloxacin, Avelox, are broad-spectrum antibiotics widely prescribed for urinary tract infections, respiratory infections, and skin infections in older adults. QT prolonging drugs include a wide and surprisingly diverse group: antiarrhythmics, amiodarone, sotalol, quinidine, antipsychotics, haloperidol, quetiapine, risperidone, certain antidepressants, citalopram, escitalopram at high doses, antihistamines, diphenhydramine in Benadryl, azithromycin, Z-Pak, and methadone, among others. The mechanism: torsades de pointes. The QT interval on an electrocardiogram represents the time it takes for the heart's ventricles to electrically depolarize and then fully repolarize between beats. Multiple drugs prolong this interval by blocking cardiac hERG potassium channels, IKR current, which are responsible for repolarization. When the QT interval is excessively prolonged, typically above 500 milliseconds, the heart becomes vulnerable to a dangerous arrhythmia called torsades de pointes, TDP, French for twisting of the points, which describes the characteristic spinning pattern seen on ECG. Torsades de pointe can degenerate into ventricular fibrillation and sudden cardiac death. Fluoroquinolones independently prolong the QT interval, When combined with other QT prolonging agents, particularly antiarrhythmics or antipsychotics, the effects are additive or synergistic, dramatically increasing arrhythmia risk. Additional risk factors for TDP in older adults include female sex, hypokalemia, hypomagnesemia, bradycardia, and underlying structural heart disease, all more common in older populations. What the research says, the FDA has issued multiple warnings and label updates for fluoroquinolones regarding QT prolongation risk. A pharmacovigilance study in the European Heart Journal found that the combination of fluoroquinolones with other QT prolonging drugs significantly elevated sudden cardiac death risk compared to either drug alone. The Credible Meds database, crediblemeds.org, maintained by the Arizona CERT, provides a regularly updated, publicly accessible risk classification of drug-drug interactions involving QT prolongation and is used by cardiologists worldwide. What to discuss with your doctor. Before accepting a fluoroquinolone prescription, inform your doctor of all current medications, including psychiatric medications, heart rhythm medications, and any medications taken as needed. Ask whether a non-QT prolonging antibiotic alternative is available. If you have a known prolonged QT interval or a history of arrhythmia, this conversation is especially important. The polypharmacy problem. Why this keeps happening. The drug combinations described above are not obscure or rare interactions buried in pharmacy textbooks. They are well documented, clinically recognized, and preventable, yet they continue to harm and kill older adults every year. Why? Fragmented care. A typical older adult with multiple chronic conditions may see a cardiologist, an endocrinologist, a rheumatologist, a urologist, and a primary care physician, none of whom have complete visibility into what the others have prescribed. Electronic health records are improving but remain fragmented across health systems. Each specialist optimizes for their organ system. No one is managing the totality of the drug burden. Over-the-counter blind spots. Physicians frequently do not ask about over-the-counter medications, and patients frequently do not mention them because they don't think of them as real drugs. Aspirin, ibuprofen, diphenhydramine, Benadryl, antacids, and herbal supplements all have clinically significant interactions with prescription medications. This is perhaps the most underappreciated source of dangerous interactions. Age-related pharmacokinetic changes. After approximately age 60, the body's ability to process medications changes significantly. Hepatic blood flow decreases, reducing first-pass metabolism. Glomerular filtration rate, GFR, declines, slowing renal clearance. Body composition shifts toward more fat and less water, altering the volume of distribution for both fat-soluble and water-soluble drugs. Plasma albumin levels may fall, affecting protein binding. These changes mean that standard adult doses can produce much higher plasma concentrations in older adults, amplifying both therapeutic effects and toxic effects of all the combinations described above. The Beers criteria. The American Geriatrics Society publishes and regularly updates the Beers criteria, a list of medications that are potentially inappropriate for use in older adults, taking into account the pharmacokinetic and pharmacodynamic changes of aging. Many of the drugs discussed in this script, benzodiazepines, certain antihistamines, NSAIDs, certain antipsychotics, appear on the Beers criteria. Asking your doctor or pharmacist whether any of your medications appear on the Beers criteria is one of the most evidence-based questions an older adult can ask. Your medication safety action plan. The following steps are supported by clinical guidelines and pharmacist organizations for reducing polypharmacy risk. Step 1, create a complete medication list. Include every prescription drug, over-the-counter medication, vitamin, mineral, herbal supplement, and as-needed medication. Include the dose, frequency, and the name of the prescribing physician. Keep this list updated and bring it to every medical appointment, every pharmacy visit, and every emergency room visit. Step 2, use one pharmacy. Using a single pharmacy for all prescriptions enables the pharmacist to run interaction checks across your entire medication profile. Pharmacists are among the most accessible and underutilized members of the healthcare team for medication safety, and their medication therapy management, MTM services, are often covered by insurance. Step 3. Ask for a medication review. Request a comprehensive medication review from your primary care physician or a clinical pharmacist annually, or whenever a new medication is added. Ask specifically, are any of my current medications interacting with each other? And are any of my medications on the Beers criteria for older adults? Step 4. Question every new prescription. Before accepting a new prescription, ask, what is this for? What are the most important side effects? Does this interact with any of my current medications? Is there an alternative with fewer interactions? Step 5. Deprescribing conversations. Research strongly supports that older adults are often on medications that were appropriate at one point in their life, but are no longer necessary or whose risks now outweigh benefits. The deprescribing movement in geriatric medicine aims to systematically review and reduce unnecessary medications. Ask your physician, are there any medications I'm on that I could safely try stopping or reducing? Step 6. Check crediblemeds.org. For QT prolonging drug interactions specifically, the free public database at crediblemeds.org provides up-to-date risk classifications for thousands of drugs. It is maintained by university researchers and used by pharmacists and cardiologists. Key mechanisms. Summary. The dangerous combinations covered in this script share common biochemical themes. 1. Enzyme pathway competition. Multiple drugs competing for the same metabolic enzymes, CYP3A4, leads to accumulation and toxicity. Statins plus CYP3A4 inhibitors, Digoxin plus antibiotics. 2. Additive receptor. Effects. Two drugs acting on the same or complementary receptor systems produce amplified effects beyond what either does alone. ACE inhibitors plus potassium-sparing diuretics, hyperkalemia, opioids plus benzodiazepines, respiratory arrest. 3. Dual impairment of protective mechanisms. Two drugs each partially disabling the same protective system, such as hemostasis, combine to eliminate it almost entirely. Warfarin plus NSAIDs, SSRIs plus NSAIDs. 4. Renal clearance. Disruption. When a drug depends on kidney function for elimination and another drug damages the kidneys, or when kidney function changes with age, plasma levels rise unpredictably. Metformin plus contrast dye, digoxin plus amiodarone. 5. Cardiac ion channel. Convergence. Multiple drugs independently blocking the same cardiac ion channels, HERG-IKR, produce additive QT prolongation and arrhythmia risk. Fluoroquinolones plus antiarrhythmics or antipsychotics. The most important takeaway from this information is not alarm, it is empowerment. Every one of the interactions described here is known, documented, and preventable when patients and physicians are both informed. The older adults who are harmed by these combinations are almost never harmed because of negligence or carelessness on anyone's part. They are harmed because our healthcare system was not designed to manage the complexity of multiple conditions, multiple specialists, and multiple medications in an aging population. That is changing slowly. Pharmacy-driven medication reviews, electronic prescribing alerts, deprescribing programs, and geriatric pharmacology training are all improving, but the most reliable safeguard available right now is an informed patient who asks the right questions. Bring your complete medication list to every appointment. Use one pharmacy, ask about interactions, ask about the Beers criteria, ask whether every medication you take is still necessary. These are not burdensome requests. They are evidence-based practices that clinical organizations worldwide recommend. Your medications can extend and improve your life. Understanding how they interact with each other is part of how you make sure they do.